Hi, everybody. So this is video lecture number 4 of this endocrine academic half-day series. Today, I'm going to be talking about congenital adrenal hyperplasia. This is a special video. It's not part of, it's not going to be a part of my second academic half-day, since there were some requests regarding clarification on congenital adrenal hyperplasia, because it does come up in both precocious puberty and adrenal insufficiency. So I decided to make a separate video just to focus on this condition. Again, so when we talk about adrenal hormones, we refer to adrenal cortex hormones, right? And I mentioned in my previous video lecture, there are 3 zones, right? Zona glomerulosa, fasciculata, and reticularis that makes aldosterone, cortisol, and sex steroids. So what is actually CAH? What is it? So it is a genetic defect in one of the enzymes that involves in adrenal steroidogenesis that leads to the deficiency of adrenal hormones, particularly cortisol and aldosterone. Remember, those 2 hormones are very important, has many, many biological effects. So since you have a deficiency of cortisol and aldosterone, it sends a positive feedback to the hypothalamic pituitary adrenal axis, causing an extremely elevated ACTH. And remember, ACTH is a trophic hormone, so it stimulates the growth of adrenal, causing adrenal hyperplasia. So the name implies, back before they discovered the enzyme deficiency, most of these infants did not survive because they died of adrenal crisis. And during autopsy, they found that these infants have a very large adrenal glands, hence the name congenital adrenal hyperplasia. Now, there are many forms, but about 95% of all cases are due to 21-hydroxylase deficiency. So when you talk about CAH, sometimes, most of the time, it will be referred to 21-hydroxylase. Now, the board exam only asks about 21-hydroxylase deficiency. I have yet to see a pediatric board exam asking other forms of CAH because it's so rare. Unless you want to become a pediatric endocrinologist, then we'll be talking about other forms of CAH. So let's recap a adrenal steroidogenesis, because it is important to understand CAH. You have to have some basic understanding of adrenal steroidogenesis. So I simplify the whole pathway, right? This is where most residents get confused because of the pathway. So I simplified it, right? So what is the precursor of steroids? They're all cholesterol, right? So cholesterol has to be transported into mitochondria. Majority of adrenal steroid production occurs in mitochondria, right? So cholesterol gets converted to pregnenolone, right? Very important step. Pregnenolone gets converted to progesterone, right? Now sounds familiar, progesterone. Also, pregnenolone can be hydroxylated at the position 17 to become 17-hydroxypregnenolone, and it's converted to 17-hydroxyprogesterone. Remember, this sounds familiar, right? Because this is what the newborn screening does. They screen the level of 17-hydroxyprogesterone. Now, both progesterone and 17-hydroxyprogesterone can be converted to other intermediary, right, by 21-hydroxylase. So 21-hydroxylase is here. Now, there are one more step before it becomes cortisol. We're going to leave that out because it causes nothing but confusion. Aldosterones require 2 more steps, right? So 21-hydroxylase block this process, right? Now, 17-hydroxyprogesterone can also be converted to the androgen pathway, right? So Remember this DHEA, right? The enzyme that add the sulfate group to DHEA only occur in adrenal gland, right? So this, once it's become sulfatized, it's become DHEAS, right? So it is very specific to adrenal, right? So um, again, 21 hydroxylase block at this um, step, right? So what happened when there is a deficiency of 21 hydroxylase activity, right? So the blockade is here. So what happened? 17 hydroxyprogesterone gets accumulated, right? So what happened when you don't have enough cortisol and aldosterone, you have a positive feedback. So ACTH even stimulates this pathway, and it even cause more blockade, right? And it is accumulation of 17 hydroxyprogesterone. So 17 hydroxyprogesterone can be converted to this one, androstenedione, or can be converted to androgen. So the end product is an accumulation of androgen hormone, androgens as well. So you have an elevation of 17 hydroxyprogesterone, which then convert into androgens. So what happened in an X46XX in utero, right? So you have an exposure to androgen, your external genitalia can become masculinized, right? So this is a simple diagram showing where the defect is. Now, what makes it more difficult is that there's a spectrum of the phenotypes in 21 hydroxylase deficiency, right? So if there's only one phenotype, it makes our lives easier, right? But because of this disease, it's a spectrum of clinical manifestation. So it depends on how much residual enzyme activity you have left, right? In a very severe form, very, very little amount of enzyme activity, what happens? So you have an adrenal crisis, right? Early on in newborn period. Or because of the accumulation of the androgen, you have an ambiguous genitalia. However, it only occurs in 46XX only. I'm going to explain in more details in the next slide. Okay. How about those that had some residual enzyme activity? So they have enough enzyme activity that you make enough cortisol and aldosterone. So you don't have adrenal crisis, but because of an accumulation of androgen, you present with signs of precocious puberty, right? Remember, they usually present with signs of adrenarche, right? Or even milder form than that, they don't present until adolescent, right? So excess androgen in adolescent, they look like PCOS, right? So this is the spectrum of the 21 hydroxylase deficiency, from very severe to very mild. Now, I'm going to touch base on this sex differentiation because it's important in order to understand the effect of androgen in utero, right? If you guys want me to review DSD, I can do in a separate video. I used to do it a few years ago during academic half day, but I found out it was just too many details and they don't ask that many questions in board review, so I cut it out. But if you want to understand DSD, I can make another short version of the DSD, right? So this is a simplified version, right? So remember, in utero, you have a bipotential gonad that can become ovary or testes, right? So one of the gene that triggers testes formation is SRY, right? So sex determining region on Y chromosome. And that's the reason Y chromosome, the most important function of Y chromosome is testicular differentiation. So once it triggered the testicular formation, so testes, remember, two groups of cells, Leydig cells and Sertoli cells. Leydig cells secrete testosterone, right? So testosterone can masculinize external genitalia. Testes also consists of Sertoli cell, right? So what does Sertoli cell do? They secrete anti-Müllerian hormone. So what does an anti-Müllerian hormone does? what does an anti-Mullerian hormone do? It causes a regression of Mullerian duct structures. What are those? Uterus, fallopian tube, and upper two-thirds of vagina. Remember, uterus, fallopian tube, and upper two-thirds of vagina. The lower one-third of vagina is considered external genitalia, right? So this is a simple diagram, right, of an external genitalia formation, right? So in utero, very, very early, 6 weeks in utero, you have a big opening, right, and a structure that will become phallus, right? So with the exposure to androgen, right, what I remember is that androgen always close, right, from posterior to anterior, right? So it caused a labia fusion, right, an enlargement of the phallus become penile chaff, right? And also urethra extended to the tip of phallus, right? So this is the effect of androgen, right? So you can have an masculinization of external genitalia if you have enough androgen exposure in utero, right? This is an example of what's happening when a 46XX, which is a severe form of CAH, and that they make enough androgen to masculinize external genitalia. You can see that there's a fusion of the labia, right? What's supposed to be labia now looks like scrotum, right? And there's a phallic structure, right? So this is a 46XX with a severe form of CAH, right? Now, in this situation, you shouldn't be able to palpate gonads because they are adhere next to the fallopian tubes, right? Because Mullerian duct structures are there. Very, very important. It's going to come and help us when you see an ambiguous genitalia, right? Remember, physical exam and some simple investigation. So let's recap, right? So if you have a newborn with severe 21-hydroxylase deficiency in 46XX, what happened with it with the adrenal function, external genitalia, and internal duct structure? In the 46XY, I'm sorry, I mentioned 46X, it's 46XY. Yes, they have adrenal crisis, right? They don't make enough cortisol and aldosterone. They have normal external genitalia. Why? Because they make testosterone, right? So they were supposed to masculinize their external genitalia, right? Having an extra androgen wouldn't change anything. And then the internal duct structure, it is male structures, right? Vas deferens, epididymis, because they have an AMH, right? So AMH makes those Mullerian duct structures regress. What about 46XX, right? Right. They also have severe deficiency of cortisol and aldosterone, so they present with adrenal crisis. External genitalia is masculinized because they're exposed to androgen. How about the internal duct structure? It looks like female, right? Because they don't have AMH. This is a very important point. They have androgen, but they don't have AMH. So the Mullerian duct structure did not regress. It develops into vagina, uterus, upper two-thirds of vagina, uterus, and fallopian tubes, right? This is very important. It's going to come back and help you when we do the case illustration. Now, you probably, many of you have seen newborn screening, right? One of the screening is that they screen for a CAH. How do they do that? They do 17-hydroxyprogesterone level, right? Remember, back to the pathway, it's accumulated and it's the most sensitive hormone to do the screening, right? Why do we do that? Because we want to prevent adrenal crisis. Adrenal crisis usually don't happen right away. It occurs around 2 to 4 weeks after birth, right? So it is mainly to detect severe 21-hydroxylase deficiency in 46XY. Why? Because in 46XX, it usually get picked up by ambiguous genitalia, right? Because once you have an ambiguous genitalia, all of these infants will be evaluated, right? Unlike 46XY, they look completely normal, though, right? So they can be missed. So the most reason why newborn screening was created to detect CAH, because many of these 46XY infants did not have an evaluation, and they later developed adrenal crisis, right? Now, when we talk about late onset CAH, remember, go back to the slide about residual 21 hydroxylase activity. So if you have a deficiency in 21 hydroxylase activity, but not severe enough to cause adrenal crisis, so you present with signs of adrenarche, right? So this is true in both 46XX and 46XY. Now, in a case with even less severe form, right, you can present with PCOS picture, right? It will happen only in 46XX, right? 46XY with a very mild form of CAH, sometimes they don't present with anything, right? So this is the reason why 21 hydroxylase can be misleading and not as simple as we thought. So in terms of treatment, right? So in a severe form, we have to replace the deficiency, right? So we give them both hydrocortisone and a mineralocorticoid, which is fluorocortisone, which is Florinef, right? So we give them both glucocorticoid and mineralocorticoid. Now, in late onset or less severe form, most of the time we only give hydrocortisone. Why do we do that? Because we need to suppress the androgen production, right? Some places recommend to give Florinef, right, to help reduce the dose of glucocorticoid, but it's still controversial, right? So that's pretty much the treatment of CAH, and we do the same thing with adrenal insufficiency. We do the stress dose, and we only do the stress dose for hydrocortisone. You don't need to stress dose mineralocorticoid. Now, in an emergency situation, you give IV hydrocortisone large enough that it can also have a spillover effect to mineralocorticoid receptor. Okay, so let's do some case illustrations so make you understand better the presentation and the diagnosis of CAH, right? So this case one, you're evaluating an 8-year-old boy because of early pubic hair development. His onset 2 years ago, right? Remember my lecture on puberty? This is definitely precocious puberty, right? He started 6 years old. And the amount is increasing. He also has body odor. Past medical history, family history, and review of systems are unremarkable. Remember, history is still very important, right? Physical exam, his height is on the 50th percentile, and his tan are 3 for pubic hair, and testes are 3 ml, so 2.5 centimeters, and no penile enlargement, right? Again, there's no signs of central puberty, right? There's no testicular enlargement, right? So this case, definitely not a central puberty. So he has signs of androgen. So we have to find out what are the possible sources of androgen, right? It could be adrenal gland. Remember, it could be due to adrenarche, right? It could be an adrenal tumor, or it could be CAH. Remember, sorry, I was trying to there's some noise in the house. So anyway, it could be adrenarche, adrenal tumor, or CAH, right? So, for remember the case during puberty, academic half day, case with adrenarche, right, was very, very mildly elevated DHEAS, right? An adrenal tumor and CAH is usually more severe. or it could be a testicular tumor, which is also unlikely because you don't feel any mass in the testes, and testes size are pretty normal. Or an exposure to androgel, right? Because right now there are many people using androgel. This patient could be exposed to. So what do we do? Now we're going to need some laboratory investigation. So we sent lab tests, right? So his testosterone was slightly elevated for his pubertal stage. This is probably a little too relaxed criteria, but 24, it's slightly elevated, right? DHEAS was slightly elevated as well. But look at the level of 17-hydroxyprogesterone was 4,500, right? So remember, it is right where the blockade is, right? So that's why it's an accumulation of 17-hydroxyprogesterone, right? I happen to order a bone age. In this case, his bone age is 11 years. So this is a confirmed case of congenital adrenal hyperplasia, right? This is a late onset. Why? Because he has enough 21-hydroxylase activity. So he did not present with adrenal crisis, right? And this disease is an autosomal recessive. I did not mention earlier, but it's an autosomal recessive. Now let's look at case 2. You're evaluating a newborn infant with ambiguous genitalia, right? So it's a full-term baby, family history, past history, prenatal history, review system were all unremarkable, right? On a physical exam, you notice a phallus size of 2.5 centimeters. Patient has bifid scrotum, a single perineal opening, right? And no palpable gonads, right? What do you think of this? Very difficult to say, right? Because remember, this could be an XY that is under masculinized or an XX with masculinization, right? So when you see a patient like this for the first time, don't commit yourself to say, oh, this is XX or this is XY, right? It could be either or, right? It can look very much alike. So we need some investigation. So we send pelvic ultrasound, right? So you notice fallopian tubes, your normal uterus, gonads are visible next to fallopian tube. What can we conclude from just this information? There is a androgen production, right? Because there's fusion of labia, there is a enlargement of phallus, right? There's also signs of androgen. However, there was no AMH production, right? Because the patient has fallopian tubes, has uterus, so there was no AMH production. So what can this be? The gonads are unlikely to be testes because there's no AMH production, right? So it's usually when you have testicular formation, you often have both Sertoli and Leydig cell formation. So it is very unlikely to just have Leydig cell formation without Sertoli cells. So these gonads are likely to be an ovary, right? Ovaries. So this is more likely to be a 46XX with in utero exposure to androgen, right? Why do I say in utero exposure? There's fusion of labia, right? There's enlargement of phallus, right? So those are the signs of in utero exposure of androgen. Now, I send FISH for karyotype is 46XX, right? I send lab result, I send laboratory tests. This patient has 17-hydroxyprogesterone of 12,000 with some accumulation of androstenedione and testosterone, right? Renin extremely elevated. Now, renin is very difficult to interpret in newborns because they are usually elevated, right? So this case is a severe form of 21-hydroxylase deficiency in an XX individual that caused masculinization of external genitalia. Now let's look at one more case. This is an 8-month-old, right, girl with pubic hair development, right? The onset was about 4 months ago, right? Very early, very, very early. Past medical history, family history, review of system was unremarkable. The patient's full term. On exam, you found a 10-3 pubic hair that covers mons pubis, right? There's a mild enlargement of clitoris. There's no labial fusion, and vaginal opening is visible. Now you see a urethral opening above vagina, right? What does that, do you think this androgen exposure occur in utero? No, right? Because there's no labial fusion. The urethral opening is in a normal position, right? It seems like a postnatal exposure, all right? So now you understand better. When I see signs of androgen, right? So I often look for, is this in utero or is this postnatal? This case is probably postnatal, okay? Because there's no labial fusion, there's urethral opening is in the same position, right? Just the pubic hair and some clitoral enlargement. Possible sources again, could be adrenal, right? Adrenarche is probably unlikely because sounds more severe, right? The patient is very young, there's significant amount of pubic hair. CAH, right? Could be, right? Could be like one of those that had a kind of severe form, but enough 21 hydroxylase activity to produce aldosterone and cortisol. Or it could be adrenal tumor, right? So androgen secreting adrenal tumor. Other sources of ovarian tumor is unlikely. Okay, so that's when we need some investigation. So this is what happened. So I sent testosterone very elevated, 17-hydroxyprogesterone and androstenedione both are elevated, but look at the DHEAS, 4,336, extremely elevated, right? So remember back to the case during academic half day, right? That case, many patient thinks is an adrenal tumor, but is not, right? So it is actually an adrenarche. Unlike this case, that DHEAS is very, very elevated with very early onset of an adrenarche, right? So this is a classic example of an adrenal tumor causing a precocious puberty. All right, so we did an MRI and there's a large adrenal mass on the right side. And in a surgery, this is found to be an adrenal tumor, okay? So this is a real case. All 3 cases are real cases, okay? So I hope you guys understand a little bit better about CAH. I'm gonna post this on YouTube and I'm gonna turn on comments, and if you have questions, you can write on the comments, and if I can answer them, I'll try to answer them.